please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
There you are.
I'm here.
I'm so excited.
And in black and white, just as we are.
But this is blue, but it looks black. You're there.
Yeah. Okay.
I get to go first.
Okay. So much to unpack today. So I just got your email. So I will let you introduce the wonderful news.
You got the email? Isn't that just, this is the IRS granting 501c3 status to the American Academy of Resonance Medicine. It has been on my to-do list for 3 years. And then there was George, and then there was Adam and the clinic. And finally, my lawyer retired in December.
Okay.
And I said, is this on your plate or mine? And he said, it's on yours. There's an easy form. I said, you need to help me with the easy form. He said, no, I'm retiring. So my new lawyer, I said, I will pay you to sit down with me because this form is not easy.
Okay.
Anyway, that was 3 weeks ago. And this is our approval. So this is not the Frequency Specific Research Foundation.
Yeah.
This is for all resonance therapies, I guess, no matter what, and we'll have to figure out how to manage that. And you and Dave Burke and Ben Catholi said, yes, you would be on the board 4 years ago. And I'm sure you all forgot.
No.
And thanks to Candace Elliott, she was encouraging me persistently, you have to get this filed. And it's, hang on, I'll get there. Here it is. This means that we can accept tax-deductible donations. We need a treasurer, but we accept tax-deductible donations. And the charitable purpose of the foundation is to fund research on the effects of resonance therapies, including FSM, and as a secondary goal, to fund patient care for indigent patients and home devices for them, for patient treatment. We did it. Yay!
That is so exciting. And what a way to start the show off. So now I have nothing important to talk about anymore because you just.
Bye, y'all.
No, that it is so exciting. There is, and it's funny because one of the topics I wanted to talk about today was how we talk about FSM. And a lot of the questions I get asked are, how do you explain this to a patient, an athlete, a doctor, a surgeon, a person you meet in the street? And there are so many different ways that we can explain what we do. And then the next step or the next kind of questions, are there any studies, or depending on who you're talking to, and having a board and having an organization like what you just mentioned, it just brings so much more credibility to those of us that are in the field. So this is a super exciting moment.
I had a research foundation. I made somebody else president of it in 2011. We were approved as a 501c3. And then things happened and it was rescinded when the president didn't file the taxes. So I've been waiting since 2012. So 12 years to do it again. And so here we are. And it's really interesting that you would come up with that. How do we explain what FSM is? Because that question has come up for the website in conversation like a lot in the last week. And the explanation I have seems to be one that makes everybody happy. So I'm going to throw it out there and see what you think about it. The getting it concise is tricky, but the easiest way to explain it is human cells or cells in your body have receptors on the outside that respond to drugs and nutrients like a key in a lock. So the receptor is like this, and the pharmaceuticals like Advil and supplements like vitamin C land on those receptors, change how the inside of the cell works, and changes what the cell does. Frequencies act like your key fob, like the frequencies from your key fob, changing that receptor with a frequency instead of a chemical. Now, sometimes you need both, but if you used your key fob to open your car door today, you have used a frequency specific technology to change a receptor from open to closed. And that it just takes it all away. If they want to go on, then there's cell physiology and kinases and messenger DNA and messenger RNA and microRNA and cell responses and infection and blah, blah, blah. There's way more detail for medical providers. Are there any studies? Of course there are. We have animal research and human research showing that one frequency to reduce inflammation reduces inflammation better and faster than any prescription or non-prescription drug ever developed. Really? Yeah. And then the rest of the papers that we have published are all in clinical cases for applications of different frequencies in clinical situations, like delayed onset muscle soreness. And then, depending on who you're talking to, you can say, I will say to a medical audience, this control trial, placebo-controlled trial on delayed onset muscle soreness, had an N of 22. And the p-value has 2 zeros and a 5. And you can tell who in the audience understands statistics, because that's impossible.
Mm-hmm.
With a prescription drug to get a p-value of 0.05, not 2, actually it's 0.3 zeros and a 5. For a prescription drug to get a p-value of 0.05 takes close to 1,000 patients. It's a huge N because of the way the math is done in statistics. So FSM is easy to do research on because the changes we get are so big with such a small number of patients, even in a control trial.
Mm-hmm.
So what are you good at? That's where the guest list gets long.
Mm-hmm.
And the plural of anecdote is not data, which is why we bribe people to produce case reports. Now we know that we have a protocol that reduces the incidence of breast cancer reduces the risk of breast cancer in patients with fibrotic breast tissue, reducing it in 8 sessions from a class 3 to a class 2. It's an N of 1,
Mm-hmm.
but it's just a huge response. So there's more papers coming. I'm so excited.
And that will continue the conversation. Again, going back to the key fob and
Analogy.
totally, it's enough information for a layperson to wrap their head around the fact that the mechanism of action is something that you don't see and you don't feel, yet it is effective, right? So lock, unlock, big forerunner, little fob, it works. Those of us who work with athletes run into a whole other stumbling block, because I feel like they don't need the how does it work? Why does it work? It's you fixed my friend, you fixed my teammate uses this machine, I want the same. But the question typically is, how come I don't feel anything?
Oh, that's easy.
Yes, you with the beautiful white pearl necklace.
What do you tell them?
So I explained the key fob. We talk about the analogy with the opera singer singing the note. So we talk about the mechanism, how scar tissue almost vibrates apart. I use the bridge analogy depending on who my audience is. But for athletes that have multiple games in a week, so football players don't necessarily care about this so much because they just play for Sunday. They live for Sunday. So they have 6 days to get hit by a Mack truck and then repair before game day. But if you have an athlete that is playing 3 times a week, they are not afforded that luxury of an elbow in a piriformis or a contraption. So I explain the benefits of not necessarily feeling anything because it's preserving the superficial tissues on top of the deep. And so that sometimes is enough. And then I'll walk them through the fact that you will feel it, but you will feel it in a different way. And the athletes are so kinesthetically aware that they'll feel it in a different way. But you tell me what.
The one I use with athletes is the reason you can't feel it is the microcurrent uses the same kind of current that your body produces on its own, but it increases energy production in the cells by 500% in 30 minutes. So it gives you 5 times the energy you had when you walked in the door,
Right.
to repair the tissue.
Yes,
We
absolutely.
have frequencies that reduce inflammation. I got data on that. You don't want to know about it.
Mhm.
And they understand energy.
Absolutely. And when I bring up the fact of if they like the big TENS machine or they like the big PEMF that is very threshold,
Oh, that's
it all works the same. However, and then I bring up that point that you were saying. I said, when you're working at amperage at that level where it's extremely sensory, you are decreasing energy in the cells. So
Yeah.
it is sub-threshold. You have the ability to increase energy. And that typically is enough for any athlete, for any of us that are even weekend warriors. More cellular energy. Yes, please, I'll take 2.
And it's physiologic. Your body can use it. If you blast it, your body says, no, thank you. Ow, that's too much.
Right.
You want to slide right in so your body won't resist.
Exactly.
And then the frequencies just change how the tissue operates.
Right.
So that it doesn't hurt. Yeah. So
I had a question the other day. There's like a group that come to see me, different athletes, and they all switch off. And one of them said, did you ever think that your results are just because you're a really good manual therapist and you do really good corrective exercise prescription? No. And
yeah.
For sure. And I said, oh, I know I'm a really good manual therapist and I am really good at corrective exercise. However, I was doing that before FSM. And once you feel change happen so fast, you can't unsee it. You can't unfeel it. So I said, as good as I am, I know that this helps what I do with the tissue. And I know when patients treat themselves at home, so that everybody that has custom cares for home use, when they're still getting benefit and I'm not in their house, then that comes to me programming the machine correctly. And that's something else that I want to circumvent about today is the mode bank prescription versus really tailoring a prescription for somebody. Yeah. And to me, that is the most important thing. So yes, I couldn't work without my precision care. No, I couldn't work without a custom care, but the most important part is the software with that custom care that enables you to customize, adapt, pivot.
Yeah.
Because if you're doing your job as a clinician and the therapist is doing their job by using the machine as they should, that prescription should be continuously changing. if we're on the right track, if we're healing, and that brings me to my quote really quickly before I get totally.
What do we have a quote?
Healing doesn't mean the damage never existed. It means the damage no longer controls your life.
Oh yeah. Amen. Yeah.
And that's going to bring me back to another set of words pretty soon. But okay, I just unpacked quite a bit there. But I want to give people tools. I want to give patients the right phrase to talk about FSM in the right way. And I want to give clinicians the right phrases, because we are in so many different fields: veterinary medicine, chiropractors, PTs, surgeons, rehab, nurse practitioners, like acupuncturists. There's so many of us that are using this. And I think we universally have to have the same message. So again, having the board
message is, it increases the thing we know for sure. And I like to stick to facts. When people get too airy-fairy about resonance medicine and frequencies and harmonics, whatever. I'm data driven. And so what we know, what we have data about, is the current by itself increases, you have to say cellular energy because people don't know what ATP is, increases cellular energy by 5 times. You don't have to work for it. You don't have to, it just gives you free energy.
Yep.
The frequencies, the data we have says that the frequency to reduce inflammation reduces inflammation in animals and humans better than any prescription or non-prescription drug ever developed. The other frequencies, I don't have a lot of data on, but clinically, those frequencies seem to change how different pathologies affect the cell. Right? And then that just depends on what they want to know, how much they want to hear, where they're coming from. Are they a medical physician? Are they a surgeon? Are they if they're a naturopath? And what they're interested in is treating the GI tract, right? So I have a patient with irritable bowel, Crohn's, SIBO, small intestine dysfunction. So if you can reduce inflammation by a factor of 10 times in 60 minutes, and you can increase ATP production in the small intestine by 5 times in 30 minutes, and if you can improve the function of the vagus nerve to control inflammation, control digestive motility, control the microbiome, if you can do all of that, how much easier is it going to be to improve the patient's small intestine? Now, the other, and I lectured to a group of naturopaths a while ago, and the key phrase for them is FSM buys you compliance. And they go, oh, it's like you think about your patient encounter, you take their history and you palpate their abdomen, and it's tender and it's bloated and it's uncomfortable and their pain levels of 4 or 5. And you then look them straight in the eye and you say, okay, I want you to remove these 6 foods from your diet. And I want you to take these 5 supplements. And in 3 months, you're going to feel better. And you watch the patient's eyes glaze over, and you can see the little bubble forming over their head saying, oh yeah, sure, see you, bye. But you do the history, you palpate their abdomen, and then you say, would you mind if I tried something on you? You won't be able to feel it. And I just want to see if it's going to change how your abdomen feels. And then you run inflammation. frequency for inflammation in the small intestine and plus encapsulated. And you run basically the small intestine protocol, even for 20 minutes. Their pain goes from a 5 to a 0. The bloating goes down by even 50%. And they get kind of floaty. And then you sit them up. And then you tell them, okay, I want you to take these. Let's start with these 3 foods. I want you to take them out of your diet for 6 weeks. And I want you to take these 2 supplements. And I want to see you next week. They're out of pain. They now believe you. And they will do what you say because you created an immediate change. It's actually the same thing with athletes.
Mhm.
You have somebody with scar tissue in their subscap or their hip or their gastroc and soleus from a fracture or whatever, an injury. And you change the scar tissue and the range of motion. And then you tell them to do these exercises. What's your compliance like?
Yeah, it's fantastic.
Yes, ma'am.
Right.
Because there's a right now change.
Right. And I think that's when we start getting the questions of, you have a patient that has this big, long history and you have to treat 1,000 things. And where do I start? What's going to get them out of pain? That you have to treat the mold and the
Vestibular injury and the.
Yeah, absolutely. But public enemy number 1 is always what's going to get them out of pain right now.
Mm-hmm.
If you don't do that in treatment 1, you may not get treatment 2. It is complicated and overwhelming at times when you see the patient history that makes you want to just put everything down and say, I'm going to go home.
I'll catch you next time.
But we can't do that. But again, if you can just, again, boil it all down and we talk about pattern recognition and we talk about following the breadcrumb and all the other things, just getting them out of pain. And so whether that's running concussion or treating the nerve or something.
Supine cervical practicum is bread and butter.
Yes.
I have a case that came in this week.
Do it.
Can I do that?
Yes.
Okay. Because our first claim to fame was 40 and 10, was the 47 cases that I took to IFM, the 30 cases that I took to NIH, and the cytokine research, and 58% of fibromyalgia caused by spine trauma recover from fibromyalgia in 3 months. That's data. We got that. All right. So I had a patient come in this week that her history goes back to the age of 15 when she had a viral infection in her inner ear, dizzy and hearing loss and tinnitus and all that. But then you go through the timeline and there's this 30-mile-an-hour head-on T-bone accident in 2005. And she is a fibromyalgia patient, but her pain level is now a 4. And I said, what was your pain level in 2000, whenever that was, 5? And she said, oh, it was a 7. And I said, it was a 7. She said, gradually over about 10 years, it got better. Okay. She said, but I'm still sore to touch everywhere and I don't sleep. And she's on good medication, nothing stupid, things that help. She's a medical practitioner, so she understands how things work. And I've never seen one. All of the fibromyalgia from spine trauma that I saw and treated were acute. Their pain level was an average of a 7.3, right? They were acute. The spinal cord was inflamed. Her disc recovered. The spinal cord remyelinated or scarred over or repaired. And she still hurts all over. So I tested the tender points at the beginning of the treatment, the second day, because the history took 3 hours. The second day, did the tender points, they were tendered to 2 and 3 pounds per square inch. But she's centralized. When you've had a level 7 pain for 10 to 12 years, your thalamus amplifies pain. We have a frequency for that. From neck to feet, I ran 40 and 89. The same thing we do for thalamic pain, for central sensitization, quiet the thalamus. And she said, yeah, and my legs are always so tight. And down by her knees, her hamstrings are tight, her quads are tight, her paternias and brevis is tight. We know that's loss of descending inhibition. So you increase secretions in the spinal cord. So I had 2 machines on her from neck to feet, increase descending inhibition in the cord, and quiet the thalamus. And then I just worked on her neck. Now she's got this 5-6 disc bulge that has to be pressing on the motor pathways in the center in order to get her legs to be tight. So I took the supine cervical practicum and I focused on the upper cervical facets. I didn't do the whole thing. And then I spent the last 20 or 30 minutes on just torn and broken in the disc annulus, because her major pain complaint is in between her shoulder blades. So she gets up off the table. I said, what's your pain level? And she said, I don't have any. My neck's a little sore, but that pain between my shoulder blades is gone. I said, yeah, I treated the disc. And then we tested the tender points, and she went from 2 and 3 pounds per square inch pressure to 5 pounds in 60 minutes. It's the first time in 30 years I've ever treated anybody that was a chronic fibro. And she'd been treated by another FSM practitioner that did 40 and 10 that should have worked. They did 40 and 89, but they didn't run it long enough, and they didn't combine it with the treating the disc. The things that bothered her were the pain between her shoulder blades coming from the disc annulus. So what you said is absolutely, you have to treat what's bothering them.
Yeah.
It was like, it made yesterday so much fun.
Just hearing you, and this is why I love the podcast, and I love doing it before it was a podcast, when it was just you and I that chatting during COVID all the time.
Yeah.
But sometimes when you say it out loud and you teach it to somebody, you hear it in a different way. And these are all messages that we've heard for so long, but you explaining it just reminded me of when we're talking about the first couple lines in the concussion protocol. And I believe that, and I don't know if it's still like this in the core, but the phrase was, if you've ever applied a Band-Aid to a screaming toddler, you get this, right? It's just calming the situation down. And then once it's at a certain level, then all the dominoes start going. So again, if you can hit the pain right away, even if you know there's a whole other land that you need to investigate, it just taking that activity, right? We talk about all the time with athletes, we're like, you're here and I need you out of here. So it's reversing it when you're dealing with somebody who's in, especially who's been in chronic pain. And for someone who's been in chronic pain for so long, it's just bringing it down to a level of that state of confusion that they're in because they've been in pain for so long, and they search for it. But I think running 40 and 89, like you said, if you're running it long enough and you're running it during the treatment, that really expedites absolutely everything.
That's what was wrong with her. It's
Right.
that she was centrally sensitized. But the thing that made the huge difference, honestly, was the education part of it. So she said, there's this pain right up by my bra strap. That's coming from the disc. And I keep the Cloward diagram
Yes.
on paper, and I showed it to her, and she said, oh, it's my rhomboids. It's like, no, it's the disc.
Yeah.
What activities make the pain between your shoulder blades worse? Oh, when I work at the counter. Aha. What are you doing with your neck? For 20 years, she's had fibromyalgia. Nobody ever told her it was coming from the 30-mile-an-hour head-on collision or
Right.
T-bone,
Yeah.
and that it's from the disc bulge in her neck and the facets in her upper neck. They
Right.
both, I showed her the referral patterns for both. They both land right at your bra strap.
Yep.
And she comes in, her whole body is tender. That's the central sensitization. That's the thalamus. Her whole body is tight. That's 81 and 10.
Yep.
And torn and broken in the disc annulus and inflammation in the cartilage,
Right.
what's making her bra strap hurt. So you do all three of them at one time, and she gets up off the table going, excuse me? I love my job.
And you've broken it down. And of course, when you reverse it, it makes so much sense. What you explained makes total sense. And I think especially when they've tried what should have worked, the 40 intense, that practitioner that ran 40 and 10, that should have worked like that. You're right. But again, speaking of when you take it one step further, the whole, and like you explained with the history, it is 40 and 89. It is the thalamus that's creating.
And then telling her where it came from. So
Yeah.
she comes in with this foam mattress that she carries with her because it hurts to lay on a chiropractic table. It hurts to touch her. So she carries this foam thing in with her. And as she's packing it up, I've already told her, you don't get to do anything with your arms out in front of you, elbows at your side, and you don't get to bend your neck. So she rolls up this foam mattress and she's bending her neck and she's got her arms out in front of her. And he reached over and I grabbed her arms and I said, no, this is how you do this. And then I showed her, elbows at my side, roll up the thing, and you keep your neck straight. You don't have to look at it. You know where it is.
Yeah.
And you do this. And she went, I said, your pain is not coming from space. It is this thing in your neck.
Yes.
And it is fixable.
Yeah.
There's hope here.
Yeah.
It's just a rough job.
I'm going to go back to the ugly face that I made and the eye rolling and the hair pulling for a second.
Okay.
That's what happens when someone says tight rhomboids.
Oh God. Yes.
And I understand the patients that come in with it because they've been told that by typically a massage therapist
Or a physical therapist.
Yeah, or physical therapist, because that's what they're doing with the muscle. But I'm going to even disagree with that because the rhomboid, like the trigger points in the area or localized area of contracture, however you want to say that, are typically deeper and they're running on the paraspinals and the iliocostalis thoracis, which are on top of the ribs.
And the longismus thoracis, which are innervated by C5-6.
Thank you. Muscles, we talked about this last week. Muscles can't push, they can only pull, they can only contract. And your rhomboids, when they're doing their job, retract the shoulder blades. And so if your rhomboids were tight, you would come into the clinic with retracted shoulder, and nobody comes in like that. Your rhomboids are perpetually elongated because we're slouched and we're flexed forward. And so they're getting longer, and little slips of them may try to contract, but they don't. And those little areas can get tight. I'm not debating that. So trigger points can absolutely happen there, but they're not creating the pain and they're not creating the dysfunction, is what I'm getting at.
Thank you very much. Exactly.
So this actually is a good segue to unpack a question that we got emailed to us, because there's a lot in the question that I think is very fitting for today.
Yes.
The question says, unsure on how to prioritize order of treatment when someone presents with disc and or facet inflammation and probable ligament instability from their mechanism of injury. So the example is whiplash. And the person continues to say, as the subacute and chronic disc and facet protocols in the mode bank contain scar frequencies, and these, if I understand correctly, can worsen ligamentous instability, which does one treat first? 24-100, so torn and broken in the ligament, and avoid scar frequencies until the ligaments are repaired? Or can one treat ligamentous instability and scarring simultaneously? In the core, it says, prepare for worsening if using scar frequencies when ligaments have been injured. But what about if someone presents with psoas adhesions and a ligament tear in the knee, for example? Should the psoas treatment wait until the knee is completely healed, or is it enough to run 24/100 on the knee while treating the psoas? So lots to discuss really quick.
I'm gonna let you start because I know what I would say. So if you have a ligamentous injury in the knee, where did it start? If they took a hit in soccer and actually damaged the ligament, that's one thing.
Yep.
But is it postural and gait related? So the real question, is there any way to repair a ligament in the knee if the psoas is short and tight and the knee, because the hip is internally rotated and flexed, therefore the knee is going to be valgus? Are you ever going to be able to repair the ligament in the knee until you fix the psoas? So you have to think in your world, you think about everything is connected to everything.
Mhm.
So in my world, you treat the psoas.
Mhm.
Is the psoas ever the psoas?
No.
It never is. It's always scarring in the ureter, scarring in the kidney, sclerosis in the fat pad. If somebody's got a 27 degrees scoliosis in the lumbar spine, then the psoas might be actually the psoas. But
Right.
for most people, it's the ureter and the kidney. So you treat that first.
Mhm.
Is that going to damage the knee?
No.
I don't think so, because am I treating scarring in the ligament? No, I'm treating scarring in the ureter. Well, different frequency. And if the frequencies are as specific as they appear to be, then I'm not going to hurt the knee. Now, if you have two machines, you can multitask. You wrap a towel above and below the knee and you run 124 and the meniscus 214, because there's no way to damage the ligaments without damaging the meniscus.
Yep.
So you run that while you're working on the psoas. Then as the femur unwinds and allows the knee to be straight, then treating the knee is easy.
Yeah.
Did I miss anything?
Yeah, a little bit. We're going to go to the example
next-
that you gave.
Yeah,
Yeah,
yeah.
because so
The-
I'll let you unpack that and then I'll unpack a bit too.
and you opened with the answer to that.
Yeah.
So it's if the patient is, so why would you use something out of the mode bank that it doesn't fit this patient?
Right.
So the patient mostly has torn and broken in the ligaments, torn and broken in the discs, torn and broken in the connective tissue, inflammation in the facets. So the thing that I keep going back to so we have a practicum this weekend in Troutdale. We have 20 people, 3 from Canada, all over the country, MDs, everybody, PTs, OTs, DCs. And in that practicum, the most important thing to recognize about the cervical spine is the upper cervical facets are always associated with a lower cervical disc. If you have a lower cervical disc and you have neck pain and midscapular pain, like this lady from yesterday, when you have a disc, your brain puts your neck in extension to protect the disc, and that jams the other upper cervical facets.
Mm-hmm.
So once something is inflamed for a really long time, what happens to it? It gets scarred. That's what subacute refers to. That's why there's scarring in it.
Yeah.
And if it's more acute than that, and the bigger problem is inflammation in the facets, torn and broken in the ligaments, and torn and broken in the disc, do that.
And that's, I guess, what kind of jumped out at me, is because they had mentioned the mechanism of injury was whiplash. So the scarring doesn't come from space. The scarring, and if it even is scarring, sometimes it's just what we call splinting or muscle guarding.
Yeah.
Because there's ligamentous instability from the mechanism of injury. So this happens in motor vehicle accidents, sports collisions, you name it, it happens. When you run the torn and broken, especially if you're doing something like the supine cervical where your hands are on the patient, you can feel the splinting and you can feel the guarding let go, because you are addressing the torn and broken in the ligament. So even though you're not treating with scarring, the tension that is abnormally there will normalize or neutralize, and you're not even running the scarring frequencies.
Yeah.
So I think that's the important part of it. Is I get it. You may think that there's scar tissue there, and you may think that there's muscle splinting and guarding there, and you have to treat a tight muscle, but it was all there. Mechanism of injury is a torn and broken injury.
Yeah.
And so when you layer the frequencies, or when you treat it appropriately, and especially hopefully everybody's giving some sort of corrective exercise, especially when it comes to flexion extension. So whether it's just a postural thing, looking in the mirror, side bending, going into neutrality, going into extension, something to activate those muscles in the right way. So I always explain it's driving manual transmission in your car. It's that feeling of pushing the gas and taking your foot off of the clutch, or as Dr. Roger Bilica says, taking out the bad and putting in the good. It's just, you're not running scarring and leaving them in a vulnerable state. You are addressing it appropriately, and that will take care of prioritizing it.
And the thing that's neat about FSM is we don't treat what's there. We treat the cause. Why are the muscles tight? I did an hour-and-a-half podcast this morning with a cranio instability group from Germany, man who has a group in Germany on cervical cranio instability. And he said, you have a frequency for ligaments. What kind of response do you have when you're treating instability? And I said, the muscles are splinted, but they're splinted because the ligaments are loose. So they're dealing with alar ligament instability or transverse ligament instability. And so the muscles are just jammed and they're in pain.
Mm-hmm.
He said, what sort of response do you have? And I said, the ones that we've treated that I have data on, it's 3 to 6 months.
Mm-hmm.
And he just went, because typically doing exercises, the surgical outcomes in instability, upper cervical instability patients are horrible. The only ones I treat are the failures. So it must work on somebody, but I don't ever see those.
Right.
And when we treat torn and broken in the ligament, the muscles soften.
Mm-hmm.
And once the muscles are not spastic, that's where your corrective exercises come in.
Mm-hmm.
Then you have the patient close their eyes and just move their eyes.
Mm-hmm.
Now the muscles can relax and contract. And that's all the exercise they get to do. And you don't even get to sit up. Then you have them eccentrically contract and concentrically contract. And that's all in the practicum.
Yeah.
And
yeah, no, that's such an important point to make, because when there's any type of instability, whether it's in the neck or whether it's in something like the shoulder, we don't necessarily need to rush to surgery to tighten up ligaments, and there's a difference between muscle splinting and guarding and having strength in the surrounding musculature to provide support. So that is the job of the good clinician. Again, it's that manual transmission. It's as you're correcting the abnormal muscle splinting and guarding, you're not telling those muscles to turn off all the way. You're saying you still get to do your job, but I'm going to show you how to do it in a healthier pattern. And so they still are providing the support to an otherwise quote unquote lax area, but in a a better, more effective, healthier pattern so that they're able to turn off as opposed to muscle splinting when they're just on all the time. And that's what creates the trigger points and the scarring and the pain.
Yeah. And the muscles that are working too hard in some cases are working too hard because there's some muscles that can't work at all.
Absolutely. They're inhibited or they're for a reason. That's right.
So you fix why they're inhibited.
Yeah.
And all of a sudden they can turn on. And then the ones that are on guard, protecting everything super tight, they can go, oh, thank God.
Yes.
Now I can go back to normal. And then the two of those muscles, the muscle couples, need to have a conversation.
Yeah.
Like, no, I can do my job, really. I don't think so. No, really. Come on, you can do this.
Yes.
And so we had a patient this last week who had both hips replaced, but it was an anterolateral replacement.
Mhm.
And so the surgeon's solution, you know, how you have to disconnect all the external rotators, rather than cut the tendons, he just cut the end of the greater tuberosity off.
Oh.
That's a good face. And it didn't entirely heal on one side. And because it was done anteriorly, there's a lot of adhesions pulling her femurs interior, which gave her knee pain.
Mhm.
Then she had a broken ankle, and that ankle wasn't right. And basically in 2 days, her hips are now externally rotated or in neutral. Her ankle is in neutral. We had to, and she's an 81 and 10 because of her neck. And so she went from hunched over, internally rotated at the femurs. One ankle is cattywampus, limping, wobbly, balance is off. At the end of 2 days, she's standing up straight, her legs are straight, her ankle is taped.
Right.
FSM doesn't fix everything.
Yeah.
And she's now walking even. All that happened in basically 5 days.
Yeah.
That's so cool. But it was a combination of things.
And that's always good to remind everybody. So there's a couple other questions that we got live today before we run out of time.
Got it. Is scarring in the ureter?
Okay.
Almost always. It's, let me move this over here. You ask them, have you ever had a kidney infection? No. Have you ever had a kidney stone? No. And I go back to that swimmer. Have you ever fallen flat on your back on the pool deck? Yeah. Anytime you get bruising to the kidney fat pad or the kidney, all it takes is 1 or 2 drops of blood running right down the fascial planes along the psoas. And you have adhesions between the ureter and the psoas.
Yeah.
And the brain is going to shorten the psoas to protect the ureter.
Right.
So when the hard part is one of the patients that had tight psoas, she's a scuba diver and no kidney infection, no kidney stone. It's, have you ever fallen on your back on a pool deck, on a boat deck?
Yeah.
Not that I recall. If you think about the number of years she's been diving and the number of years you spend on a boat, is there ever going to be a time when you
Right.
haven't fallen flat on your back?
Yeah.
Your back's a little sore for 2 days and then you forget about it. So no, I didn't ever fall. But it's usually
Some sort of trauma like that.
Sure.
Next comment, just wanted to say thanks to the core. I understand my groin pains may not be a result of my car crash, but could have been a result of epidurals and scarring in the area of L4. For 20 years, I was totally unaware there could be a reason for psoas tension, hip, knee, and low back pain. I didn't even notice my lumbar was stiff. I ran dura adhesions and all frequencies for trauma, bleeding, scarring for each disc, long program, and the pulling is gone. I'm still in disbelief. Now I can't unsee it in all mothers, especially post C-section. How common is it in your practice?
In mothers, yep. In athletes, yep. In endometriosis patients, yep. It comes from someplace. Now that you can't unsee it, welcome to our world. I'm sorry and you're welcome. I love that line. It's great.
Further to last week, right hip responding to joint subacute across SI.
Oh, interesting.
Some nerve root compression, maybe a component, can't find localized pain near spine. Importantly, it is, as Carol said, regional muscles all have elevated tone and so squeeze the moisture out of the joints. They also fatigue themselves. Eventually also recognize only small slips of muscles were spasming. A full muscle spasm would have resulted in moving the joint, abducting and rotating the leg. So that kind of comes from that global splinting when we're seeing biomechanical changes, and then localized area of contracture, a term some people call trigger points, when you have small slips of a muscle trying to do what the whole muscle does.
Well, and the thing that stands out in what you were saying, Thad, is when you look in, God bless David Simons, when you look in Trevelyan Simons and you look at the glute minimus and the medius, but mostly the minimus, and where it attaches and where the pain refers. So that's the minimus is such a teeny little muscle, and it's this external rotator. And when you look in the trigger point manual, it says trigger points in the glute minimus and medius are perpetuated by, also caused by, but perpetuated by SI joint dysfunction.
Yeah.
So if you have a strain in the SI joint, and the rheumatologist that was in my class last time, I have to go look this up because she said the lower SI joint is the synovial joint and the upper one is the fibrous joint. And I've been saying it backwards for years, and I have to go look it up because I'm not sure she's right, but she believes her version as strongly as I believe mine. So I've got to go look it up.
Okay.
But anyway, if the SI joint is lax, if it's been injured, you look for the injury. Did you land on your butt? Did you hit your knee? And it's the glute minimus. It's this little teeny muscle that's buried deep.
Mhm.
And it's an external rotator. And it's, like you said, it's a little slip.
Mhm.
But when you treat the SI joint, that muscle relaxes. David Simons is right.
But again, it just all boils back down to when you treat the driver, when you treat the cause, right? Muscles don't, it's like happiness. Nobody wants to be unhappy, but there's situations that cause us to be unhappy sometimes, right? So it's just like saying, just be happy. Okay, but you have to remove the driving of why I'm so angry right now. So why is the SI angry, or why is the glute med angry? It's because the SI had trauma and it shifted the pelvic mechanics and it's holding on for dear life. So that's that.
Speaking of happy, Michelle, I'll get to you in a second, but I have to tell you guys, just so you can think about your calendar for next year.
Yes.
We have been invited to do a core seminar at Anamaya Resort, Health Resort in Costa Rica. That's near Montezuma in Costa Rica. And he said the course goes from Saturday to Saturday, and it's normally we do Wednesday to Sunday. And he said, no, you fly on Saturday. The course starts Sunday. You do Sunday, Monday, Tuesday. Then you take Wednesday off for brain rest and exercise and walking on the beach and clearing your mind. And then the course is the Thursday and Friday, and then you fly home Saturday. And it's, wait, we could never do that in the United States.
No.
People won't take the time out. And in Costa Rica, are you crazy? We wouldn't do 5 days in a row. You're brain dead after day 3. So take day 4 off.
We could put the podcast live in between that. It's perfect. It's on a Wednesday.
Yeah, I'm just so excited.
Amazing. So there's always so much to look forward to. But
November,
we have 1 minute left, and let's get to Michelle's question. Michelle says, when kids get injured in karate, I've been using a torn and broken protocol in the custom care, but members of my family ask, why don't I run general inflammation? I always second guess myself when thinking about inflammation, thinking the swelling happens for a reason. So I'd rather prioritize hitting the 4-hour window of an injury with torn and broken.
And stop the bleeding. It's
Yes.
like when you look at, remember that diagram of the cell that I have in the core, where you've got the little receptor and you've got TNF alpha and you've got inflammatory peptides hitting it. Blood outside a blood vessel is part of the cascade that starts inflammation.
Yeah.
So yes, you do the 4-hour window. Inflammation is a result, not the cause.
That's right.
Torn, broken, and bleeding are the cause. You have to treat inflammation, but you treat the causes first.
Yeah.
Stop the bleeding, treat the trauma, treat the torn and broken, and then treat the inflammation.
And like I've been preaching, especially when we talk about using heat versus ice so much, the inflammatory response can be helpful because the macrophages come to clean up the debris. So you don't want to take away all inflammation. It's just when inflammation goes a little crazy that we want to intercede with that. But when you treat the torn and broken and the bleeding, the inflammation never really gets that bad. So taking out those two drivers is the more important part. So you did it right.
Yes, stick to your guns. And if you look at the delayed onset muscle soreness protocol, it only runs 20 minutes.
Yeah, exactly.
And the p-value has 3 zeros.
Right. It's good.
I rest my case.
It's a good closing note. So
Yeah, there you go.
treat the cause. So hopefully that helped unpack a little bit of verbiage semantics today. I think it always inspires me when I talk things through. So hopefully it helps everybody listening.
Isn't that fun? That's
So much fun. So we'll see you next week. All right, everybody. Keep the emails coming. These are great questions.
do good things. Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.